Hi, I'm Dr. Nick Weddle with ScoliosisKC, and today we are doing the scoliosis consultation video. So I will be seeing you soon for either an in-person consultation or a Zoom consultation. I will need to have an updated scoliosis x-ray at a minimum, or if you don't have one, we can take a new updated scoliosis x-ray when you're here. This will give me at least the needed information to get a basic idea of where you are at today in terms of your scoliotic curves, scoliotic presentation, and then that can help us to get started talking about actually what your condition looks like. It depends on if you're an 8-year-old or you're a 15-year-old or if you're a 45-year-old. Each of these kind of stages in life with scoliosis will have different goals in terms of what we're doing in treatment. Now, the overall treatment in general is focused on reducing the scoliotic curve, improving the normal sagittal plane curves, and then improving motion, improving kind of all the different functional factors. But there are kind of nuances with regard to where you are in life, especially with regard to kids and with regard to growth. So if you're a 12-year-old who's actively getting ready to grow and go through a big pubertal growth spurt, that's going to change in terms of how we're going to focus on treatment initially. We don't have 6 months or 9 months where we can wait and get started slowly at our leisure. If we're facing growth spurts right away, that's going to change. We're going to have to work much sooner. So we'll talk more specifically about those with regard to where you are exactly at, and this is different for every patient. One of the most important things about idiopathic scoliosis is that it's not actually a spinal problem. Idiopathic scoliosis is more of a neurological and a hormonal condition where the primary manifestation of it is in the curve in the spine when you're looking at the spine from the front. So it's a distinction, but it's important because it's not really a problem with your spine, or the muscles are simply doing what your brain is telling it to do. And so when we go about treating it, that changes how we go about the focus. It's important to make the distinction that idiopathic scoliosis is not purely a two-dimensional reality, where this means that when you're looking at just an A to P scoliosis x-ray and you're looking at Cobb angles, that's a two-dimensional. The reality is your spine is three-dimensional. So we don't want any curves from the front or back, and the spine should be straight. So scoliosis is when we have these side curves. But what is almost never talked about is that when you look at the spine from the side, the sagittal plane, we need 3 curves: a curve in the neck, a curve in the mid-back, and a curve in the low back. And so our treatment focuses on not just trying to reduce the abnormal scoliosis, but also trying to normalize the sagittal plane alignment so that you can be upright to gravity and the body can function as it's intended to. So every week I sit and do consultations with families, many who have come directly from like the orthopedic world, and they are just looking for something better. And so a big part of what our program focuses on is trying to just create a rehab-based program that's specific to your scoliosis. I say this a lot when I talk with patients that I see families, whether it's a 10-year-old or a 40-year-old with scoliosis. The reality is, unless their curve is big enough for surgery, there's not a whole lot of options that they're giving you. And so a lot of families are looking for something. Let's say you have the same back pain. Let's say you with scoliosis and have another family member who doesn't have scoliosis present with like the same back pain. Say you were in a mild car accident and you go to physical therapy. They are prescribing you the same physical therapy basically they'd give me if I had the same pain symptoms. And so a big part of our program is simply taking you and looking at you three-dimensionally. So both understanding the coronal plane with your scoliosis, understanding your sagittal plane, what the normal curve should look like, and then I am developing a specific rehab program that's designed exactly for you and no one else. And so in doing this, we can create a program that actually can change the curves of the spine, including the scoliosis. But I see patients every week who have been told by the doctors that exercise can't change scoliosis. And yet, when we look at what they're being prescribed, it's not scoliosis specific. So you'll hear me say this a lot, but that is one of the most important factors, is it has to be specific to your body and to your curve pattern, and you are unique and different than anyone else that we know with scoliosis. The standard of care for typical scoliosis treatment really starts with just watch and wait. There's no treatment involved. And so when most kids, especially, are diagnosed with scoliosis, they simply are going to watch and wait to see if these curves progress. And so diagnosis is at 10 degrees. And so again, I've had patients that had 8 and 9 degree curves. It's still scoliosis, is just small. So the reality is that it diagnoses at 10 and then there's really no treatment offered until that curve gets up to around 20 degrees or 25 degrees, where the standard hard bracing is recommended. After that, from the range of 25 to really about 35 degrees is where they will attempt bracing to try to stop the progression of the curve, but not to reduce it. I speak with families every week who have come from kind of the orthopedic management, where they're told bracing is not designed to reduce a curve, but only an attempt to try to stop it from progressing. And I argue that A, that's not true. We can often reduce curves quite a bit with good bracing and with good active rehab, but this is the standard of care that most families are being presented with. For patients that get up to that point, around 35 to 40, we see most of them are just treating them as just surgical candidates. So there's really no treatment. They might say, if you have a lot of pain, go do physical therapy, but that physical therapy is the exact same physical therapy they would prescribe me, someone without scoliosis. So when we talk about this, it's really, really important that we're actually looking at what is three-dimensionally happening with that person, and we're not gonna waste time waiting to see if the curves progress. We're gonna work now at reducing those curves and stabilizing those curves, whether you're an adult or whether you're a 14 or a 12-year-old kid. We don't wanna wait for progression where it just gets worse. It makes it harder to reduce that later on. So given the importance of looking at the spine from a three-dimensional model, the exam that we're going to perform is going to reflect that. We will do a three-dimensional x-ray series. So not only looking at the spine from an A to P perspective, looking at the scoliosis, but also from the sagittal or from the side, looking at the sagittal plane curves. And so every one of these measurements that we're looking at in these x-rays will be used to determine the specific exercises and rehab that you'll be performing. So this is real important because this is almost never evaluated by anyone else in terms of scoliosis treatment. Another unique part of our evaluation for scoliosis is not just focusing on the actual Cobb angle, the curve, but more on flexibility. So if a person has, say, a 30-degree Cobb angle, that's pretty much all they are identified as. Like that's their whole identity in terms of scoliosis. And the reality is that doesn't actually give us that much information about your overall condition. It just means that while at rest, your curve measures 30 degrees. And so one of the things we will do is called a lateral bending or a bending x-ray. And so I will have the patient stand and actually bend out of their curve pattern, and then we'll take an x-ray. So what this shows me is overall flexibility. And so if a patient goes from, say, 30 degrees to 4 degrees, right, and that patient then would have 26 degrees of flexibility, that's really good comparatively if, say, the exact same patient or, identical twin sister went from 30 degrees to only 20 degrees with this lateral bending, giving her only 10 degrees of flexibility. So both patients could present with the exact same Cobb angle, but yet their overall outcomes will be completely different. Additionally, when we go through the exam, many patients who present with a thoracolumbar or a primary lumbar scoliosis will often have substantially tilted pelvis or sacrum. And so I keep running into patients who have this and no one has ever evaluated for it. So one of the things we will do is perform an evaluation on the pelvis and leg length to determine if there's a structural leg length or even a structural pelvic abnormality, which could be contributing or even causing the actual scoliotic curve. Now, this would change from this being an idiopathic scoliosis to being more of like a leg length inequality scoliosis. But what I keep finding is nobody talks about this. And I see a number of kids even recently coming from the Children's Hospital, and all they're doing is watching and waiting, come back in 6 months, but they have never evaluated the structure of their legs or this. And I'm finding many of them are having where their scoliosis is actually caused by or even aggravated by significantly this presentation of the pelvis. So if this is a need of you, we will evaluate for this as well when we go through the exam. So in the overall CLEAR Scoliosis Rehab Program, we have a number of exercises and specific rehab and pieces of equipment that we are using in what originally we called the mix, fix, and set. This was the CLEAR way of describing a program where we get through mix, which is the warm-up. So to get the spine flexible enough to change, we're going to go through a number of therapies, including the MDP and the Eckert table, and the vibe traction to kind of prepare the spine and get it more flexible and more warmed up and ready to kind of change. The set is the chiropractic adjustment, so we're doing a very specific chiropractic adjustment that's designed specifically off of each patient's x-rays. So it's not the classic kind of rack-em crack-em adjustment that a lot of people are familiar with. We do some manual adjusting, we do mostly instrument adjusting, especially for the neck. And then finally, the last part is the NMR, or kind of the set procedure. So going back to talking about scoliosis, since it's not just a structural problem in the spine, but that this is a neurological and hormonal, then the focus of our rehab is not so much just like we're trying to strengthen a muscle or any of the muscles of the spine. We're trying to change how the brain is communicating to those deep core spinal muscles, which largely you and I don't have any conscious control over. So it's important to be able to understand, because if you go to the gym or you go to physical therapy, the majority of exercises that you will do are isotonic exercise, meaning a muscle contracts and that part of the body goes through a range of motion. Yet most of the muscles of the spine, especially dealing with scoliosis, are not like consciously controlled muscles. So exercises that we have to do need to be more isometric, so more like resistant weight versus an isotonic type exercise. And then the other fact being intrinsically controlled versus extrinsically. And this is more of just whether you're consciously thinking about this or not. So we always end up in this conversation getting to the point of, well, how do you do an unconscious exercise specifically for the spine? Because you don't have the ability, or someone with scoliosis doesn't have the ability to just go and contract one side of their spine. Like, we don't have that conscious ability of our spinal muscles. Now, you can bend and move, but that doesn't engage and change the curve in a way where we're balanced up to gravity. So the main exercise that we do, we often refer to as NMR, or spinal weighting. So we are placing weights upon your spine or on your body in strategic positions so that when you are balancing up to gravity, your cerebellum, your midbrain, has to react differently to gravity. And so you can see this in some pictures, even on x-rays I'll show you as well. But this is the main exercise that we're doing. So patients will do this in the clinic and at home, and we will teach you very specifically on how to perform these. But we will go through a number of kind of evaluations to figure out which is the most effective setup that you will use. So each of these are designed specifically for your curve pattern. So we will go through and try a number of different setups. And then to verify how these work, we will do what's called a stress x-ray. So the patient will perform this typically 10 or 15 minutes, just standing and balancing. I am going to watch them and see how that body is reacting. I need to see kind of a postural shift. I want to see an improvement in that posture. And when I see that, we will physically bring the patient back and stand them in front of the x-ray and take an x-ray, or what we call a stress x-ray, of them while they're wearing this. So often you can see the device or the cantilevers or the weights on their body, but what we're going to see is how it's changing those curves. So that evaluation will give me, the ability to see if we're reducing, say, a 30-degree curve down to 15 degrees while the patient's wearing that cantilever or that spinal weighting setup. So this is very unique because in most other kind of rehab programs, there's not any evaluative use of x-ray. So it's kind of a unique program, but we really get to see exactly how a patient's body's reacting to each therapy in this way, and we're not guessing. I always go back and say that you are more valuable than just guessing. So when we prescribe these exercises to you, we know exactly how this is affecting your body. So once we know your specifics and I am able to kind of put together your prescription for what you're going to need, whether it's a 1 or 2 week intensive, whether you're going to be doing a local program, whether you need a scoliosis brace also, typically for the progressive cases, whether you would benefit from having a scoliosis traction chair at home, or even using the Scoliosis Activity Suit. We have a number of different kind of tools within our treatment program that we can use. So once we figure that out, those will be prescribed, or that'll be what the patient needs. But once a patient's finished with the in-clinic treatment, 1 or 2 weeks or local program, kind of the typical recommendation is you're going to go home for 90 days to complete the same exercises that you've been doing in clinic. So this is kind of the minimum commitment that I need from somebody. There's no requirement long-term that you keep doing this. I just simply need, we're gonna go through the in-clinic treatment, you're gonna go through 3 months of home rehab, and then at the end of that, we'll do another updated x-ray to determine kind of progress. So at that point, you can do anything you want, whether you keep doing these exercises or you do some of them or you never do them again. There's no requirement long-term, but that's kind of the main thing that we need to see to evaluate if this program's working, are we seeing good reduction and good stabilization, and then to see how you're feeling and kind of all the subjective realities. I often normally start talking about this with a little bit of my history and kind of how I got here. But I ended up doing the scoliosis rehab I feel like I got hijacked into this. I went to chiropractic school with the intent of kind of being a family pediatric chiropractor. I grew up, my stepdad's a chiropractor, and this is kind of the care I saw. My mom's a midwife, so I've grown up around just a good natural health care my whole life. And I was at a pediatrics conference in 2006, and I heard one of the CLEAR doctors speak on this program. And the reality was, this is stuff that we are not taught in chiropractic school. And honestly, I find that we are taught an embarrassingly little about scoliosis in chiropractic school. And so I feel like I got hijacked. I heard this and I knew right away this was like my destiny of what I needed to do. And so when I think about a lot of the way we practice, every day in our clinic and seeing patients, my goal is that we are looking more comprehensively than anyone else at trying to help you better yourself in terms of your curves and your overall, spinal structure, so that you feel good, you can function good, you can go backpack Europe, you can do all the things you want to do, and that scoliosis won't be such a huge detrimental effect on your life, kind of long term. Another unique thing about our practice is that basically half of my staff has severe scoliosis. So both my office manager, Mary, both my wife, Marcy, who runs our rehab room, has severe scoliosis, and they started as patients. So one of the things that I never could have planned whenever I initially started our clinic was having staff members who have been on both sides of the desk. They've been through every day of rehab, every day doing the home exercises as you will, and so they can relate to you in ways that honestly I truly can't. I don't have scoliosis myself, but I know the reality well of what day-to-day looks like, and I feel like that's really reflected in kind of the whole experience patients will get being in our clinic. So what I want you to know is that we care about you deeply. We want to help you in not just what's convenient or easy. And so I think is reflected in how we go about care in our clinic, that we are trying to look at all aspects that we can within reason and helping you navigate what your life looks like with scoliosis, but how does this work in treatment to get you out of pain, feeling better, not a surgical candidate, or maybe not even a bracing candidate, so that you can live your best life possible with scoliosis. Because again, we know there is no cure for idiopathic scoliosis, and folks that have this, they will have this for the entirety of their lives. But I want to help you be able to live an amazing life and feel great, and to be able to manage this well. So no matter what environment you go in, whether you're going to a yoga class or whether you become a lumberjack and move to Alaska, I don't care, do whatever you love, but I want you to know how to care for your body in whatever environment you find yourself in. So thank you for taking the time to watch this video. I hope this has been helpful for you to think about what our overall program looks like, your overall condition, and it will be my joy if I get to work with you moving forward to help you in your journey with scoliosis.